Good afternoon or evening even. So I'm Professor Cheong, and we're going to be doing a webinar today on recurrent miscarriages. I'm just seeing now the participants join. So welcome those of you who've joined. We are 1 minute past, so I'll just perhaps hang around for a couple of seconds more to wait for people to come on to the webinar. Then we can begin the webinar talk. Now, what I would do also in a minute is share my screen with you. If people can indicate if they can hear me properly, they can see me properly, you know, in the Q&A box or chat box, that would be wonderful if you could do that. And if you could let me know if the volume or anything else is doing okay. Please also, you could type your questions and so on inside the Q&A or chat box, whichever one you prefer. I'll be mostly looking at the Q&A questions, so please perhaps focus really just on typing your queries and questions within the Q&A. Now, I'll do the webinar in such a way if I can answer the questions on the spot, I would. But if not, I could perhaps, you know, answer the questions right at the end. I'm aware that people might be keen to know the answers as they're joining. So, so I'm going to just share my screen right now. Excellent. Just in a couple of seconds, I will now start as we're starting to get quite a number of people joining. So welcome all again to the webinar on recurrent pregnancy loss. I'm Professor Ying Cheong. I'm from Complete Fertility. With my other academic hat on, I'm also the Professor of Reproductive Medicine in the University of Southampton. Now, I would encourage you to put your questions into Q&A box. You see that on the webinar, there is a Q&A box. Please do that, and then I can take the questions on the spot if I could. If not, I will keep them to the end of the talk, and then I'll answer them accordingly. So it's a common question in terms of recurrent pregnancy loss. People wonder sort of when this becomes really a problem. But if you look medically at this condition, you'd see that there is a definition. And medically speaking, if a woman had a loss of pregnancy, 2 or more pregnancies, then that definition of recurrent pregnancy loss would apply. And this is true from either spontaneous conception or even after IVF or assisted reproduction. It is not, you know, uncommon in terms of miscarriage. It's actually quite common in any pregnancies. Up to 15% result in a pregnancy loss. But when the condition is recurrent, clearly this becomes much less common. You can see here it's 1 to 2% of all couples. So let me just walk you through a little bit of biology, because this is sometimes what a lot of patients are interested in. And I call it the mysteries of implantation, because implantation is not the most straightforward process. And in terms of the science of it, doctors are still trying to understand this condition. But we know quite a lot about it. So in this colorful picture, a cartoon, you can see, and I will go through it with you, This figure shows a developing egg, okay? And then at some point in time in the month of the menstrual cycle or the period, the egg is released. And it is controlled very intricately by the brain, you know. There's a little pituitary gland or little gland up in the brain that controls this process. And with regard to what these hormones are, you can see here in this cartoon, there are various different hormones. Here, you have the FSH, you have the LH, which controls the initial process of the egg development. And then you have this spike of this LH hormone, which then allows ovulation to occur. Now, when ovulation occurs, the egg is released here, and when it's fertilized, you see this tiny sperm fertilizing the egg in the fallopian tube, you then have an embryo that forms. Now, this embryo that is forming clearly will need to embed within the lining of the womb. So this pink image here is the lining, womb lining, okay? Now, the embryo will need to find its way onto the womb lining at the right time with all the right chemicals and components for it to be able to sit in there and embed and develop into a pregnancy. Now, the rest of the developing egg covering, which is the follicle, continues to function within the body to support the lining. And this is the hormone that it secretes is called progesterone. And of course, if the embryo is formed well and it's embedding, it will start secreting HCG, which is that hormone that is associated with a positive pregnancy test, and that will support the initial part of implantation, if you like. And you can see that, it's not a simple process, it's quite intricate. So you have the egg developing, it has all to be right. The communication between the brain and these eggs development has to be correct. And the lining, how it grows, and its communication with hormones also have to be absolutely spot on for this little embryo to be able to grow into a pregnancy. So that's in sort of a summary of the basic processes that is happening within the uterus. Now, it is clearly not straightforward. There's still a lot of unknown with this process. You can see the interaction with the brain is never straightforward because it's via blood and the nervous system and various different systems within, biological systems within the body. There is also, of course, how these post-ovulation structure within the follicle work and how does it communicate with the tiny embryo and the womb lining and the very, very intricate crosstalk with all these structures in order to be able to promote implantation that works. Then, of course, also, how does the egg and the womb lining, the transition of it and the development is all really quite an exciting research area, but not totally understood. I just want to make this point. Actually, the process of the biology of implantation, whilst we know a lot, we still don't know quite a lot as well. So many of you will want to know clearly what the tests you should have if indeed you suffer from a recurrent pregnancy loss. Well, there are a number of these useful tests that we recommend, okay? And when I say useful, I mean really sort of medically proven, and they're things that we can do to make the condition better, okay? Now, so this of clearly a family history or medical history is very important. For example, if there is a medical history of other medical conditions, so significant problems such as severe diabetes or any other severe medical problems, of course, will affect anybody's health and also, of course, ability to carry a pregnancy. Family history as well. And then, of course, we will also be thinking, okay, should we be screening this particular condition, which you would have heard about, and it's called antiphospholipid syndrome. Now, a lot of people describe this condition as a sticky blood condition, right? But actually, that's a misnomer. That is, it's not really sticky as such, but it is an immune condition. Okay, so it's complicated and it's associated with increased ability, as you can read here, of blood clots. Very often, it may run in the family, or it may be that it started with someone taking the hormonal treatment or the pill, or it may be out of the blue that you have a history of deep vein thrombosis, which is forming a clot in the veins in your legs or even in the lungs. All right. So that's a very specific condition. Then, of course, we always will be thinking, okay, should we be looking for thyroid problems? Our thyroid gland is a very important gland up in the neck here. And it has many functions within the body. But of course, if it's not working properly, it will affect implantation and ability to carry a pregnancy. But of course, people with thyroid problems have very often very obvious clinical signs, which your doctor can pick up if you do suffer from that. Then clearly, we also need to do an ultrasound scan to check if the womb and the ovaries inside the pelvis is all looking okay, and there's no other issues such as big tumors or fibroids or ovarian cysts that may be affecting your general health. And of course, if we do find a problem that is associated with the structure or the anatomy of the pelvis, then examining the womb with a tiny telescope to look inside the womb would be important. And that's a procedure called hysteroscopy that you can see here. Now, you can see on this slide that I've really sort of put this quite enlarged, because actually many times, even if a cause is found, there may not be a treatment, right? But a lot of couples do not have any cause after all the tests that I've put out there earlier, that they are diagnosed of what we call unexplained recurrent pregnancy loss. Okay, so what are the other investigations that we can do? And some patients ask me, oh, is there something perhaps not quite right with our genetics? And so you can see here, I just give you a little example of what sometimes we find in couples with recurrent miscarriages, is that when we do genetics, so this is a sort of a complex picture, but really all I want to illustrate is if you look at this structure here, so these are chromosomes, so these are our genetic material. We all have, 23 pairs of this. So when you map, your genetics on a piece of on the karyogram, this is what this is called. You will see that everybody has that. It's either XX or XY. Now, in this particular individual, they have an immediate translocation, but it's balanced. Balanced meaning that the material exchange is equal in amount. Okay, but there are different types of translocation that can be picked up by a genetic test called karyotyping, and in some couples, it's useful to have that. Although majority of couples where they have karyotyping, it's normal. Okay, because condition that's associated with abnormal karyotype or translocation is actually not very common in couples with recurrent miscarriage. But if they do come up, then potentially there could be some explanation for the miscarriages, but also screening for the embryo form at a later stage if it's appropriate to do that. Now, let me just go back. Now, there's also, of course, another test that we can do, which is called sperm DNA fragmentation. Now, what is this? Well, this is a test to check the sperm and the DNA within the sperm. So this is different from the earlier karyotype, but this is more sort of just looking at, because there's many sperm that a man produces. Now, there's evidence to suggest that in men, right, where a couple has a recurrent miscarriage, potentially they have more damaged DNA compared to men who are healthy and fertile and don't have a history of recurrent miscarriages. And so you can see this graph here, normal in green. This is a normal, typical fertile man with no issues associated with miscarriages. And then you have the yellow, which is a little bit of damage, and then the orange is very damaged. Compared to if someone has increased damage, and this is more often found in couples who suffer from recurrent pregnancy losses, much less of the green, which is the healthy, undamaged DNA sperm, compared to the other. So you can see that actually proportionately, there are more damaged sperm. So this is useful for knowledge, and a lot of people ask me, is it worth doing it? Will we know more? And the answer is yes. If you did this test and the results suggest more damage, that's extra knowledge that you would have that potentially may contribute to miscarriages. Now, there are, however, many investigations that are not recommended. Okay, why are investigations not recommended? It's not because your doctor is not willing to do them or don't know that they exist, but it's more about when they do not provide information on the cause of pregnancy loss, when they do not help with actually selecting any treatment, and when they do not even help in giving knowledge and estimating the prognosis, meaning the outcome, how good the outcome is. Okay, so in that case, doing an investigation that doesn't allow this will not help us. In fact, many times it makes us worry about the results that actually is not helpful. Okay, some of these tests are here. Now, this is totally not recommended. All the learned societies have suggested this. The European Society of Reproduction, the American Society, the various learned societies. Okay, so I'm just going to take a few examples here and try to explain why it's not useful. Okay, I often get asked, why don't you test my progesterone? Surely if my progesterone can be tested regularly, we'd be able to pick out the time where the pregnancy needs support and just give the progesterone. Well, let's see. The problem with progesterone is progesterone goes up and down, up and down, up and down throughout the day, right? So it's impossible to pick the right minute or second. And if one were to do that, you'd need to put a line in your arm persistently, which totally it would be ridiculous. So it's pointless examining the progesterone in the blood and testing for it. We don't know what the norm is within this fluctuation. It's not really well defined. And so it becomes a futile way of investigation. So that's why progesterone is not tested to see if it's correct. Now, the other one, very, very common, patients ask me, NK cell testing. Now, what's it all about? The unfortunate thing about natural killer cell or NK cells is its name. Natural killer cells are not killers. In fact, they're a type of white blood cells. And that means it serves to control infection and is also really important in immune response. So you can't do without natural killer cells, okay? But of course, some research has definitely shown that it's associated with, it's increased in people with recurrent pregnancy loss. And this natural killer cell increase is actually in the lining of the womb, not in the blood, okay? But the role is really unclear. And so there is no real proven treatment either. So it's recommended that if you want to look into natural killer cells, then it's worth joining or participating in a research program so that we were able to understand this better. But in terms of investigations, it is really not recommended, okay? Now, so we talked about investigations, and now we move on to treatment. The good news is that any couple with recurrent pregnancy loss, actually when you look at the whole cohort across the board of people with recurrent pregnancy loss, the chance of a live birth in their next pregnancy is actually relatively high. Okay. The only problem, of course, every time I tell patients this is it's very hard to believe because they feel, oh, but you know, how do you know? When would it be? And that's the problem. We don't know when exactly which pregnancy it would be. But if you take everybody together and look across the board, the success of gaining a live birth in their next pregnancy is actually best part 60 to 70%. So that is, I think, a really good news as far as this condition is concerned. Now, clearly, this depends on a number of things, okay? We talk about maternal age, we talk about, you know, clearly because the older, more advanced age is, the less likely a pregnancy will implant properly because the quality of the egg and the embryo becomes not so good. Right? So the chances of miscarriage increases with that. And that's just purely because of the quality of the embryo. Now, also in terms of the number of pregnancy losses, again, the higher the pregnancy numbers, 4, 5, 6, 7, the chances of a successful pregnancy does decrease, all right? And clearly, if we found a cause, a lot of times we can help change the prognosis by treating it. But as I explained before, we often do not find, or many couples suffer from what we call unexplained recurrent pregnancy loss. Now, talked about antiphospholipid syndrome earlier. I told you about it, a sticky blood condition. It's not really sticky blood as such, but the treatment is anti-clotting agents, okay? So heparin, aspirin. But, you know, these are treatment, there's a treatment that you only really give if someone has the diagnosis of antiphospholipid syndrome. Now, clearly, if thyroid is in dysfunction, you have thyroxine or replacement of the thyroid hormone that is deficient, or it treat the thyroid if it's overactive. Then, of course, you have sometimes, and we come across quite often in a fertility center, women with abnormal shaped uterus and so on. Now, it is a little bit, still consensus is not there in terms of the actual exact way we could treat this uteruses. So basically the womb itself has a little partition of some degree, and it's quite a complex area. It depends on whether the partition is really big, how big it is, and so on. So your doctor, we certainly would be able to help you evaluate the condition and decide if surgery was indeed useful for you or not. And certainly it is not recommended for everybody, but it would need individual evaluation condition. Same thing with what we see there in terms of the fibroids, little polyps, which is a skin tag in the womb, scarring, adhesions, and so on. And these are conditions that needs individualizing and then treating thereafter. And of course, if you have a genetic abnormality identified, clearly we will do all the relevant investigations and treatment and counseling and so on. But I talked about if there was any genetic problem identified, particularly around the chromosome and translocation, it may be that the couple will need IVF and maybe then pre-implantation genetic diagnosis. So in other words, a little bit of a biopsy of the embryo, early pregnancy, and we suss out what the material is inside and make sure that the right embryo is being put back. But this is very, very specific, only for people with this particular genetic condition identified. Now, we also talked about the sperm. I mean, this is male. I've put here male because it's relevant to sperm, but in all honesty, for all patients with recurrent pregnancy loss, we always emphasize healthy living, healthy diet, because these have a big impact and on the prognosis of recurrent pregnancy loss. So really important: smoking, normal body weight, reduce or limit alcohol consumption, exercise, etc., etc. A lot of this you would already know. Okay. Now, in terms of hormonal problems, we have PCOS. Now, sometimes people with polycystic ovarian syndrome suffer from recurrent pregnancy loss. There's a very specific treatment that may well be suitable for them, but it's something we'll have to individualize, and we will be able to see, evaluate the polycystic ovarian syndrome and see whether they're suitable for these treatment. If the little gland up in the brain up here is secreting too much hormone of prolactin, this is specific hormone, then clearly there are treatments available that we can correct that. The important piece of information news from last year is a study which showed that people who suffer from early pregnancy bleeding with a history of pregnancy loss, it's important perhaps to consider those patients of progesterone supplementation. Okay, so progesterone, generally speaking, is not used randomly for anybody, but particularly in this study, in a subgroup of women, as you can see here, those with recurrent pregnancy loss, did show improvement of live birth with progesterone treatment. So this is something that is new. So when none of these tests show a problem or likely cause of pregnancy loss, there are no treatments available or known to improve chances of having a baby, it's still advisable, as I said earlier, to optimize the lifestyle, keep healthy, because all that will help. There are a whole host of treatments out there that people do offer, sometimes for a lot of money, but actually they're not really been proven at all to be useful, and so we do not, and certainly I do not recommend this. Some of these treatments may also actually be quite dangerous. So there are limitations to this medicine in terms of how much we know about recurrent pregnancy loss. So it's important that if you're going to seek treatment, make sure they're evidence-based and that won't harm you more than doing you good. The pathway of recurrent pregnancy care in our center, you can see there, first visit, a very basic history, but those very, very important and planned investigations. And then, of course, those tests that we talked about earlier, we always emphasize lifestyle optimization. And then, of course, encouraging people to participate in research if there were any suitable. But of course, we offer the support that's necessary so that patients feel that someone is there if they need us to support them. So talking about support, there are many avenues of support. It's not an easy condition, this is, and so it's important that counseling is available, and also, of course, nursing support. And as I explained, the good news is very often, even though it doesn't look like it's possible to believe that many of my patients are successful in their subsequent pregnancies. And here's some support information. You can also see Recurrent Miscarriage Association and Miscarriage Association rather, and also patient support if they have fertility issues. Now, fertility is sometimes an overlapping condition with regard to miscarriages. Many patients may have recurrent miscarriages, and then they then start to also suffer from subfertility, and that is definitely something we can help with, so that we can treat the condition into parallel pathways with fertility and miscarriages at the same time. And then, so this is the last slide for my presentation. I'm going to start taking some questions now. So, but you can see here that there is Julie's email. Please do email her for any questions that you want to continue to ask, or if you like to have appointments, we're definitely also very happy to arrange for you. Now, I have a question here by someone asking about NHS consideration for miscarriages, the definition of it, and for referral. And is it 2 or is it 3 pregnancy losses? What is the difference? Now, this is more a definition question. Yes, it's true that NHS often do take 3 pregnancy loss as the definition of recurrent pregnancy loss, and so very often patients are only referred to our clinic after having suffered 3 pregnancy losses, and that's absolutely true. And the reason for that, I think, very much is resources, but also the chances of someone having 3 miscarriages and then recurrently suffer from the condition, it's more so than if you had 2 miscarriages. So in other words, if you had 2 miscarriages, it could still be really bad luck. But there's data certainly from worldwide, European data also, on the fact that people with 2 pregnancy losses are already obviously need help, right? They would need. So we are quite flexible here. We would take anybody from 2 to 3 and over miscarriages, only because we understand the data around the definitions of recurrent miscarriages. Now, I will move on to the next question, which is a question on polycystic ovaries. So, are polycystic ovaries associated with miscarriage? Is there any treatment for this? Now, this is a very good question. Yes, polycystic ovarian syndrome, not just the ovaries. So, people can have polycystic ovaries on scan, but it may not mean they have the polycystic ovarian syndrome. So the syndrome will consist of their hormones being abnormal, perhaps associated with some of the signs of polycystic ovaries. So very often, perhaps with acne, hair growth, and also lack of ovulation. So the periods don't come very frequently. Now, if someone has the full-blown polycystic ovarian syndrome, indeed, this is associated with miscarriages. And as I explained to you earlier, there is some data, only small studies, but this is certainly within the European guidance, because the data has been evaluated, that there is some evidence that ovulation induction. So in other words, we control the cycle of ovulation and give specific drugs to create the cycle, potentially may overcome this problem. Now, no one really knows or understands why, but potentially it's due to the abnormal interaction, if you remember, between earlier on in the slides, the brain interaction between the brain, the gland up in the brain, and the ovaries, and how the lining is being developed, and that could be a problem in polycystic ovaries. And if you control the cycle, potentially you could eliminate that. But this is based on small studies, but they're there. So this is something worth considering, and it certainly it needs to be individualized. So it's not for everybody. Right. So I hope that answers that question. Now, the next question is, does adenomyosis cause miscarriage? Now, does it make it more difficult to get pregnant? Now, that is, again, a very important and very good question. And now, adenomyosis, for people who don't know what adenomyosis is essentially the lining of the womb, for some bizarre reason, has gone into the muscle of the womb. You know, and the lining of the womb, you know, monthly sheds, right? Now, if the lining of the womb is embedded within the muscle of the womb, it can't really shed away. So a lot of these patients have painful periods. Their womb, when we scan them, it looks slightly different. It is a condition associated with endometriosis. Okay, so that's the lining of the womb that's inside the pelvis, not just in the womb now, this is outside the womb, right? And there's endometriosis. Now, it's important, of course, if that gets excluded, but yes is the answer. It does make it more difficult to get pregnant. It's associated with fertility problems, and there is now data, including our own analysis, that is associated to a degree with miscarriage. Now, the impact, however, is not huge, right? So it's not the same as you know, some of the diagnoses I talked about earlier, but it is still a factor, I believe. So there are certain things we can do, again, in terms of managing the cycle and suppressing the disease, and this is something that we can work on if, for example, the patient is coming through for certain hormonal treatment for fertility. All right, but if it's just a usual normal conception cycles, that's a little bit more tricky, because the treatment for adenomyosis is also the same treatment that will make, there's contraception. Basically, you put someone on high hormones and that becomes a contraceptive. So it's not very useful like that. But you know, certainly there's ways to control the cycle to help the condition. Okay. Now that next question. So in thyroid, so this is something on thyroid disorder. So in thyroid disorder, is it that, oh, this is very specific now. They're asking about the type of hormones in the thyroid function test. They're saying, is TSH or T4 more important? So TSH is thyroid stimulating hormone. So it's a hormone that comes up in the brain, again, that stimulates the gland up in the neck, thyroid. And the T4 is the thyroid hormone that produced by the gland, the thyroid gland. Well, generally speaking, you do both, and then subsequently, many people may just monitor the T4, but it really, the thyroid hormone only, but it really depends on what we're talking about in terms of the thyroid dysfunction. What type of thyroid dysfunction, you know? So, but generally speaking, we do both tests, right? And what level should they be at between pregnancy and during pregnancy? Well, obviously, if there was a thyroid problem, your GP or your obstetrician will be monitoring the thyroid to make sure that they're within normal range. So that's the usual physiological range that the laboratory that does the test will provide on the blood result. Yeah. I hope that answers the question. Now I have a question here. Is there a link between early pregnancy symptoms and early miscarriages? That is a good question. Many would wonder because they think, oh, if they don't feel any symptoms, what does it mean? I don't think that there is very clear sort of, if you don't have symptoms, your pregnancy won't be going well. I mean, a lot of people worry about that. I think very often, different people detect the pregnancy hormones differently. So so you can't rely on just the feeling of nausea or the feeling of breast tenderness and so on to decide if a pregnancy is going to continue or not. I think that's too vague an assumption, and it does cause people to worry a lot. So I think those symptoms are if you are sick, obviously too sick, then clearly that's something to see the doctors about. But really, we wouldn't ask that question to be able to diagnose a miscarriage or not. So that's too vague a term to use. All right. I've got another question here. Could recurrent miscarriage cause endometriosis to flare up, resulting in further problems with miscarrying? Usually not. Endometriosis is a condition that it tends to be suppressed by pregnancy, So if the hormones are high, like if people with endometriosis often are being given the pill, for example, right? So that high levels of hormones tend to suppress the disease, probably because the lining is not allowed to grow and then regrow and then regrow, you see, because endometriosis is essentially lining of the womb inside the pelvis, not in the womb, so it's outside the womb. And it tends to flare up every month with the menstrual cycle, okay? So, so miscarriage doesn't really cause endometriosis as such. And so it's unlikely to cause it to flare up. But if you suffer from symptoms of, say, pelvic pain, heavy periods, painful periods, irregardless of history of miscarriage or not, that may be something to visit your doctor about, because of course endometriosis could be one of the conditions causing that. And it's a very common question. A common problem is that endometriosis gets diagnosed very, very late because the symptoms are not clear. So severe, painful periods, irregular periods, those are really sort of symptoms suggestive of endometriosis. If you're worried, please do see your doctor to get evaluated, and maybe an ultrasound scan and then diagnosis, hopefully early rather than late. Right, so I have got currently no more questions here that I can see. I don't know if anyone else wants to quickly type a question up or not. Oh, we've got another question now. So in your experience, have people associated with recurrent pregnancy loss with too much exercise? That's an interesting question. I will have to say I never stop people from doing exercise, because it's definitely something that should be encouraged. It is important, however, to be measured, I suppose, because if if you're talking about really excessive exercise, right? I remember having a patient a while back who has, really fanatic in doing physical exercise, a marathon this week and then an iron something else in another week, and I think that in that scenario, and her BMI was dropping and dropping to under 19, and that was too very low. So it's important that if it's overdoing it, over exhaustive, don't forget the body is a very clever system. It knows if people are tired to exhausted, it does shut down. So what happens is the hormones get dysregulated, etc., etc. But if you're talking about running a couple miles, a couple times a week, that I don't see any problem with that. And it's not about impact either, because the womb is well impacted even in a pregnancy stage. So, as long as it's not exhaustive and as long as it's not huge fatigue for the body, it should exercising should not be discouraged. I always encourage some level of exercise even in pregnancy. Okay, but that's a good question. Okay, so I'm just waiting for to see if there's any other questions. We've got a couple minutes left. If you think you've got any other questions or urgent questions, please let me have them. Now, you can type your questions to me through Julie Gale. That's the appointments person down there. There's not a problem. There's another question pop up. So the question is around using a donor. Donor, I presume donor egg, or maybe even donor sperm. Is it possible to be incompatible for fertility? The likelihood of that is low because donors are screened, they're healthy, there's a very strict criteria in terms of donating whether sperm or egg. And often donors are much younger, so the chances of a chromosomal genetic problem is low in terms of poor quality egg or sperm. So it would be unlikely. It would be very unlikely, I would say. Now, I have a question there on food. Are there any foods that are good to eat? This is that there's always lots of food that's good to eat. I suppose you mean good for in terms of pregnancy. Well, I think the key thing in terms of general nutrition in pregnancy is make sure it's balanced. I mean, there's loads and loads of diet outside, out there that you can find on social media, on Facebook, right? But I think the general consensus is one needs to be sensible. Okay, there's always important to remember though, trying for pregnancy, you need to remember to take folic acid. Okay, and clearly for those who are at risk and maybe different ethnic group, because the sunlight is not great in this country, then you be in the UK, you be thinking about vitamin D as well. Okay. Now, many people will say, okay, what about the other supplements and so on? I always say, okay, if you feel that, perhaps you've got a busy lifestyle, you're not sure if you've got all the nutrients, you're trying for pregnancy, get a multivitamins. That would be really, that should do it, because that would be sufficient with all the micronutrients. I wouldn't recommend any specific sort of diet as such, because restricting certain nutrients and so on and trying for pregnancy is not great. And I would emphasize that a good diet should also be for male and female. A lot of people assume it's just for the woman, and actually no, you heard about the sperm and so on. So it's important to make sure that it's both partners, with a healthy diet. Summer, bright sunshine, you know, enjoy the sort of sunshine, loads of vitamin D, but also take loads of fresh fruits, vegetables, greens, berries. Those are full of antioxidants and really good for you. And I'd say, you know, rather than going for a specific food type, just make sure that you eat a well-balanced diet. That would be my general advice. Now, I think I've got another minute. If you're a quick typist, please type in another question and I'll see if I can answer them. And the other thing, of course, is that, you know, please do give feedback if you feel this is useful, if there's anything you feel you want, maybe for future webinars, let us know. We'll be happy to put some up for you and all your friends, family, colleagues around fertility, reproduction. It's always, you know, delighted, you know, I'm always delighted to give a talk like that to be able to help spread the knowledge and information. And I hope I've given it enough for you today that is not too medical, so you can actually understand. Can stress cause miscarriage? The cause, I'm sorry, that's my, there's some barking outside there. So can stress cause miscarriage? Well, it's not great to have a stressful a lifestyle if you're trying for pregnancy. I've always advised people to cut down, you know, stress-causing events, but it's very hard to measure stress, so I'd say try to manage your lifestyle so that it decreases stress, but there is no direct measurement of stress in terms of the level and the chances of a miscarriage. But I would always advise my patients to minimize stress as best as they can. Right, I hope I've answered all your questions. I think we have now come to the 1 hour mark. Again, please, any questions, appointments, any feedback, please put that through to the email down below. And I wish you have a great evening. And so take care very much. Bye-bye.